Welcome to osteology classes. Today's topic is on osteology of pelvis. So pelvis is the ring of bones formed by two hip bones, the sacrum and coccyx. So here in this image we can see the ring of bones formed by two hip bones on each side. This is the right hip bone. Left hip bone, the sacrum. Sacrum is present in the midline and below the sacrum articulates with the coccyx. So these bones are united by four joints. The two synovial sacro-iliac joints which are present on the superior laterally. So here are the sacro-iliac joint is a synovial joint and most stable synovial joint in our body, which is present on each side of the sacrum, where the ala of the sacrum articulates with the ilium. And the two fibrocartilaginous joints, one is the pubic symphysis present anterior-inferiorly, so the other is the sacrococcygeal joint, which is also a fibrocartilaginous joint and where the coccyx articulates with the sacrum posterior-inferiorly to form sacrococcygeal joint. So bony pelvis is subdivided into pelvic girdle. Pelvic girdle is formed by the two hip bones, which is the appendicular skeleton, which connects the spine to the lower limb. So these two hip bones, right and left hip bones, forms the appendicular skeleton, that is the pelvic girdle. And pelvic region of spine, that is sacrum and coccyx. So the sacrum and coccyx forms the axial skeleton. Pelvic cavity, it is divided by the pelvic rim or iliopectineal line into two parts. So iliopectineal line is this line, which separates the pelvic cavity into the upper one is the greater pelvis or false pelvis, which is present above the pelvic rim. So this is the pelvic brim and below the pelvic rim is the lesser or true pelvis. So lesser or true pelvis present below the pelvic brim. Pelvic brim, which is otherwise called pelvic inlet, which leads into the lesser pelvis, and it is the superior rim of the pelvic cavity and it is bounded posteriorly by the promontory of the sacrum. So anterior border of the promontory of sacrum. So posteriorly by the promontory of the sacrum and the anterior border of the ala of the sacrum. This is the ala of the sacrum. So this forms the sacral part, which is on the posterior aspect of pelvic inlet. So anteriorly from the middle it is formed by the pubic symphysis. On each side of the pubic symphysis, there is pubic crest and pectineal line. And laterally, it continues with a line we can see forming a margin of pelvic brim, that is the arcuate line. So pubic part of arcuate line. And then this arcuate line continues with the ilium as the linea terminalis. So the linea terminalis includes the pubic crest iliopectineal line and arcuate line. So pubic crest, iliopectineal line, that is the line in between the ilium and the pubis, and also the arcuate line. All these together considered as linea terminalis. Linea terminalis is crossed by the ureter gonadal vessels and medial sacral vessels, iliolumbar vessels. So here in this image we can see the gonadal vessels and it is also crossed by the iliolumbar vessels. They supply the ilium and the lumbar region, and middle sacral vessels. So these are the blood vessels, but here in this image I can show you only the gonadal vessels and middle sacral vessels which crosses the pelvic brim or the inlet of pelvis. The nerves which crosses the linea terminalis are lumbosacral trunk, and it is crossed by the obturator nerve, and it is also crossed by the spermatic cord in males, round ligament of uterus in females, and it is crossed by the sympathetic trunk, and it is also crossed by the suspensory ligament of ovary in females. So these are the few structures which are related to the pelvic inlet. That is, to be specific, it is related to the linea terminalis of pelvic inlet or pelvic brim. Pelvic outlet is a diamond-shaped aperture bounded posteriorly by the sacrum and coccyx. So here we can see on the posterior aspect sacrum with the coccyx, and laterally by the ischial tuberosities and sacrotuberous ligaments. And the ligament connecting the sacrum and the ischial tuberosity, these ligaments are called as sacrotuberous ligaments. And anteriorly by the pubic symphysis, and it is also related to the rami of the pubis and ischium. This is ischiopubic ramus. And ischial tuberosity is projection from the ischium. So these are the boundaries of pelvic outlet. So pelvic outlet is a diamond-shaped aperture bounded posteriorly by sacrum and coccyx, laterally by the ischial tuberosities and sacrotuberous ligaments, and anteriorly by the pubic symphysis, arcuate pubic ligament, and rami of pubis and ischium. And this pelvic outlet, it is closed by pelvic diaphragm and urogenital diaphragm. So posteriorly, here is the anal opening, and here are the openings of urogenital structures. So that is the opening of vagina and urethra in female, because this is the female pelvic outlet. So anal opening is surrounded by the pelvic diaphragm, which forms the floor of the pelvis. That is, pelvic diaphragm is formed by the muscles which prevent the prolapse of the organs present in the pelvic cavity, and anteriorly it is formed by the urogenital diaphragm. So the muscles around these urogenital structures are urogenital diaphragm. So that is about the pelvic outlet. Regarding the greater pelvis or false pelvis, it is located superiorly to the pelvic inlet. So here is the pelvic inlet. So anteriorly there are no bones forming the greater pelvis. Greater pelvis, it is superiorly to the pelvic inlet and contains the distal part of the intestines, and it is bounded by the ala of ilium on each side, and also it is related to 4th to 5th lumbar vertebra. So posteriorly it is formed by lumbar vertebra which are above the sacrum. So L4, L5. And the base of the sacrum posteriorly. So the base of the sacrum also takes part in the greater pelvis. The anterior border of the greater pelvis is completed by the inferior part of anterior abdominal wall. And posteriorly the greater pelvis communicates with the peritoneal cavity. And inferiorly the greater pelvis communicates with the lesser cavity or lesser pelvis through the pelvic inlet. So the lesser pelvis, it is bounded by the either side by the ilioischial complex. So the complex between the ilium and the ischium. So this part, which is called as ilioischial complex, and posteriorly by the sacrococcygeal complex. So this is the sacrococcygeal complex on the posterior aspect, and the pubic bones, pubic symphysis and the rami form the anterior inferior border. So we can see the inferiorly the pubic symphysis and pubic bones on each side. So the lesser pelvis is bounded all around by the bones, unlike greater pelvis. Whereas in the greater pelvis, anteriorly there are no bones forming the greater pelvis, only the anterior abdominal wall takes part in the formation of greater pelvis. After about 9 months of growth and development of the baby in the uterus, the fetus is ready to born, and this is an exciting thing yet risky. The series of events that require very specific and coordinated actions. The details of mechanisms of labor require the fetal part are smaller than the pelvic diameters, and the presenting fetal parts engage or enter the pelvis appropriately. So if the fetal head is too big, the pelvic diameters are too small, or the fetal part is not oriented appropriately, that is the long axis of the head should be in the transverse plane, and then it may be impossible for vaginal delivery to take place. So the series of events which happens during the labor, it is very important and associated with the measurements of pelvis and also the position of fetus. So therefore it is important for managing obstetricians to determine if the expectant mother pelvis is adequate to deliver fetus. Additionally, the size of the fetus should also be monitored and compared with the pelvic diameters to prevent the risk of cephalopelvic disproportion at the time of delivery. So let us talk about the different types of pelvises. Gynecoid pelvis, common among the females in Western civilization. So here in this image we can see a gynecoid pelvis where the inlet is slightly oval in shape along the transverse axis. So we can see the inlet is almost oval-like along the transverse axis, and ischial spines are blunt and do not protrude into the cavity. So we can see a blunt ischial spines which does not protrude into the pelvic cavity, and oval shaped pelvic inlet, and also the sacrum is broad and has a deep concavity. So the sacrum is broad and concave, so which is ideal for a delivery. So gynecoid pelvis are most ideal kind of pelvis for normal delivery. The next variety is the android pelvis. Android pelvis is most common in male. It is called as male type pelvis, and inlet of the pelvis, if you see, it appears to be heart shaped, which is having a large sacral promontory. So we can see here it is heart like with a large sacral promontory, and also the ischial spines are conical and protrude into the cavity. So ischial spines are protruding into the cavity, and we can see the sacrum is slightly curved. So in turn, sacrum is curved inside. And this is ideal for the attachment of bulky muscles. So that is the reason it is called as android pelvis. Android pelvis is seen in females also. The next type of pelvis is anthropoid pelvis. Features of both android and gynecoid pelvis. The inlet is oval. So the inlet appears to be oval. So the inlet is oval, the ischial spines. Ischial spines are blunt, sacrum is long, narrow and less curved than a gynecoid pelvis. So it can facilitate delivery but high risk of obstructed labor. So this type of pelvis is called as anthropoid pelvis. The next is the platypeloid pelvis, called as contracted pelvis, where the inlet and the ischial spines similar to those seen in the gynecoid pelvis, but sacrum is slightly curved. So sacrum is slightly curved here. And whereas the inlet and ischial spines are similar to gynecoid pelvis, means the ischial spines are blunt. And it appears the transverse diameter is more when compared to anterior-posterior diameter in platypeloid pelvis. So the important features which differentiates male and female pelvis. So the first one is the subpubic angle. The subpubic angle is the angle below the pubic symphysis, where the two inferior rami of the pubis converge here at the pubis. So this is the subpubic angle. So the subpubic angle is around 70 degrees in males, and in females it is around 90 to 100 degrees. So the subpubic angle is more in females and less in males. And next important difference is the false pelvis. False pelvis is narrow and deep in males. So this is the false pelvis, posteriorly bounded by L4, L5, and anteriorly it is deficient, where on each side we can see the ala of ischium. So till the pelvic rim, till here, till the inlet of pelvis. So this part, the greater pelvis, it is narrow and deeper in males, and it is wide and shallow in females. Pelvic inlet, it is mostly android type in males, means it is heart shaped. So pelvic inlet appears to be heart shaped in males, and whereas in females it is mostly transversely oval. Sacrum is long, narrow with smoothly curved pelvic surface in males, whereas in females it is short, wide with abruptly curved pelvic surface near the lower end. And true pelvis, that is the pelvic cavity, it is narrow and deep in males, whereas it is roomy and shallow in females. So these are the major differences to differentiate between male and female pelvises. Pelvic fractures. Pelvic fracture refers to disruption of the bones and joints of the hip. These injuries are usually caused by the high velocity or crush injuries, and that generate enough force to break these robust bones. So there are a lot of large blood vessels and highly vascular organs in the pelvis that can be damaged during these accidents. As a result, there is a significant risk of massive blood loss and even death if these life-threatening emergencies are not addressed immediately. So the mechanism of injury will determine the type and classification of pelvic fracture. So I am going to show few examples. First one is the anteroposterior compression, AP compressions. The force is applied along the anteroposterior plane leading to diastasis, that is the separation of symphysis pubis. So the symphysis pubis may get separated, and these forces may also be transferred to sacroiliac joint, further destabilizing the pelvis. So sacroiliac joint also we can see dislocation causing destabilizing the pelvis. Those fractures that involve disruption of pubic symphysis are called as open book fractures. They are called as open book fractures. The next variety is the lateral compressions. So the force is applied laterally, resulting in inward rotation of the pelvis. So the sacroiliac joint, that is the sacroiliac region, and pubic rami are most susceptible to the fractures in these injuries. So in lateral injuries, sacroiliac region and also the pubic rami. So here we can see the pubic rami got fractured. So the sacroiliac region and the pubic rami are most susceptible to the fracture in these injuries. Vertical shear means the force is applied craniocaudally or the vice versa, resulting in the vertical displacement of hip bones. The pubic symphysis is a useful landmark when performing suprapubic aspirations or creating suprapubic cystotomy. So the suprapubic aspiration is an invasive, sterile procedure by which the urine is aspirated from the bladder through the anterior abdominal wall. The needle is inserted in the midline of the anterior abdominal wall about 2 fingers breadth above the pubic symphysis. So the suprapubic cystotomy or suprapubic catheter placement is surgically created communication between the bladder and the skin. So this procedure is used to drain the urine from the bladder in the individuals with obstructed bladder outlets. So in the individuals with obstructed bladder outlets like benign or malignant prostatomegaly or traumatic ureteral injury are a few examples which may cause obstructive bladder outlets. So this procedure is used to drain the urine from the bladder in individuals with obstructed bladder outlets. So these are the few clinical correlations which are associated with the osteology of pelvis. So let's see some differences between male and female pelvis again. So the female pelvic inlet is oval in shape, whereas the male pelvic inlet is slightly heart-shaped. The angle between the lower pubic arches, which is called as subpubic angle, it is greater than 90 degrees in women, and that is around 90 to 100, and it is less than 90 degrees in men, that is around 70 degrees. The wings of the ilium are broader and larger in women than in men. And even if you see the shape of obturator foramen, the obturator foramen appears to be triangular in women and it is oval in men. And even the greater sciatic notch and lesser sciatic notch, especially the greater sciatic notch, it appears to be more widened in women than in the men. So these are the few differences where we can differentiate male pelvis from female pelvis. So with this I complete the osteology of pelvis. Thank you.